Welcome to Physicians Health Network. This webinar is gathering steam, and we're so happy to be here once again. We're a group of Black physicians that are here to answer your medical questions. We're going to try to break it down, break all big words down, so that each and every one of us will understand what we're talking about. We feel that health is so important, especially in the time of COVID. And being a better healthcare consumer, meaning that understanding your medical problem is so important at this particular point. We want to answer your questions, so just type your questions in and we will answer any medical question. First, what I would like to do is I want to introduce each of our physicians. I'm going to ask them to introduce themselves in the order that I see them on my screen. I'm going to start with Dr. Trevor Atherley, please.
Good afternoon, everyone. My name is Trevor Atherley. I'm an interventional cardiologist. I practice mainly in the Newark area through Beth Israel Medical Center. And in addition to taking care of patients, one of the aspects of my job that I find most enjoyable is teaching and training medical students, medical residents, and young cardiologists. Thank you.
All righty. Dr. Kendall Sprock, you're on mute.
I'm Kendall Sprott. I'm a pediatrician. My background is in general pediatrics as well as pediatric critical care. I had been the acting chair of pediatrics at New Jersey Medical School for about 10 years, and now am an administrator at Matheny Medical and Educational Center in Peapack, New Jersey.
All right, thank you. Dr. Nelson Aluya, you're on mute.
Yeah, hi, my name is Nelson Aluya. I'm a medicine pediatrics trained, assistant professor of medicine at New Jersey Medical School, Rutgers, New Jersey. I'm also an attending physician at the Newark Beth Israel Medical Center, here also Newark Beth Israel Medical Center, Newark, New Jersey. I call myself a medical advocate. I'm a champion for good health everywhere. Thank you.
Right. Thank you very much. Dr. Patrick Anderson.
Hi, everyone. Thanks for having us. I'm Patrick Anderson, Chief of GYN Oncology at Newark Beth Israel Medical Center. I specialize in taking care of women with gynecologic cancers.
All righty.
Glad to be here.
Right. Dr. Kevin Clark.
Good afternoon. I'm a surgical oncologist. I work at the Newark Beth Israel with Dr. Anderson and many of the gentlemen that you see on the panel. Happy to be here today.
All righty. Dr. Dwayne Fredericks.
Hey, good afternoon. Dr. Dwayne Fredericks. I'm a bariatric surgeon. I specialize in obesity medicine and I practice in South Orange. Thank you.
All right. Thank you. And Dr. Court, at this time, we will bring Dr. Court and have him introduce himself once his mic is fixed. Dr. Jordan Garrison, please.
Good evening. It's a pleasure to be with you all. My name is Jordan Garrison. I am a general surgeon and with subspecialties in bariatric surgery and vascular and venous surgeries. My offices are in Hackensack, New Jersey, as well as Florham Park, New Jersey. Thanks.
All right. Dr. Trevor Lane.
Good evening. My name is Trevor Lane. Good to be here. I'm a medical oncologist, hematologist, practicing out mostly from Newark Beth Israel Medical Center and St. Barnabas Medical Center in New Jersey. Good to be here.
Understand that Dr. Lane is our guest physician this month, and we will be entertaining questions from cancer questions, sickle cell, anemia, all types of questions. So if you have those, definitely direct them towards us this time, and we're looking forward to answering them. Dr. Court, are you?
Should be okay.
Oh, yes, you are. Please.
Yes, you are. We can hear you.
I had to switch my computer.
All righty.
Okay. Dr. James Court.
Dr. Court, please. Your phone must be on. Is your phone on?
Okay, it's okay now.
You're getting some feedback.
Okay.
Thank you.
I'm Dr. James Court. I practice in East Orange, New Jersey, and I'm honored to be on this panel of illustrious doctors.
All righty. He's modest. All right. Thank you for joining us. Thank each and every one of you for joining us. I must state, we are a group of physicians and we're all about health, but do not change any aspect of your medical care before you see or consult your physician. It doesn't matter, I don't care what we say. It's so important that you follow your physician's directions as far as your medical care is concerned. We're here for education. Also, I would like to thank our sponsor, OBHealthy, for allowing us to pull this group of specialized physicians together to bring this webinar to you. It is so important to us that we educate the Black and Brown community at this time. All righty, let's get going. Let's start with some questions. What I'd like to do is, since Dr. Lane is our special guest, I would like to start off with him. I know, hold on for a second. We have, all right. Okay, all righty. What I'd like to do is I'd like to start off with Dr. Lane. And in plain language, this is a question that came from Jimmy. It says, in plain language, can you explain what sickle cell is and how does it differ from regular anemia?
Well, sickle cell is a congenital disorder. That means you're born with it. It's inherited from your parents, some cases from one parent, or in some cases from both parents. It's not it's not simple. There are different types of sickle cell. There's sickle cell disease, there's sickle cell trait, there's SC disease. So there's a range of it. The ones we're talking about most likely is probably sickle cell disease, the SS disease. And what sickle cell disease really is an abnormal formation of hemoglobin in the red blood cells. Okay, so the red blood cells carries hemoglobin through your body, and the red blood cells the hemoglobin molecule consists of 2 alpha chains and 2 beta chains, and sickle cell disease essentially is a rearrangement of the protein molecule in the red blood cells. So essentially what happens is that oxygen is not carried as it should on those red blood cells, and the cells become sickle. A normal red blood cells is shaped like an oval shape, like an egg shape. When the cells become sickle, they become like needle-like and they become very sticky. So they block the small arterioles and the small capillaries. So there's a diffuse and decreased blood flow to your organ system. That's what gives you pain. So the pain in sickle cell disease is really a combination of hypoxemia and inflammation. All right. So, as different from other conditions, anemia is a wide range of conditions. Sickle cell disease is a very specific one that is congenital. You're born with it. Most patients with anemia, however, develop it as a result of many things, because of bleeding, because of cancer, because of hemolysis. That's where you destroy your red blood cells. There is some degree of hemolysis also in sickle cell disease, but it is a very, very specific disease that is caused by a very specific malformation in your DNA that causes problems with your hemoglobin in your red blood cells.
Okay.
That's basically what sickle cell disease is.
All right. What I want to do is I want to ask a few questions here. You stated several things. You said hypoxia. And let's try to break the words down a little bit, because I think some of the, our audience may not know medical jargon as well as we do. So hypoxia, what is hypoxia?
Hypoxia is decreased blood flow to a particular organ and decreased oxygenation as a result of decreased blood flow.
Right.
So essentially the oxygen supply to that organ or to that nerve or to that, tissue is decreased. That's what hypoxia is.
All righty. And does anyone else want to chime in on this as far as either sickle cell or anemia, and we can get a good discussion going? Because I think it's an important question.
Yeah, so, Trevor and I have this conversation about anemia all the time, and we think anemia is a window into a lot of things. The average person don't walk around anemic. So whenever someone presents...
And Dr. Patrick Anderson, anemia is low blood count. What is anemia?
Well,
let's start with that.
Anemia is a decrease in the amount of hemoglobin in the red blood cells. And the hemoglobin is really what makes the red blood cells red. But, I always say, especially for specific diseases, anemia can shed light onto really what's going on. So for example, not every cancer patient is anemic, and certain cancers really don't present with anemia. So for example, ovarian cancer. When there's ovarian cancer and there's anemia, or when there's an abdominal tumor and there's anemia, we always look to see another source other than the ovary, because typically that disease don't present with anemia. However, there are certain ovarian cancers that do present with anemia. Anemia, doesn't mean that you have cancer. It can be abnormal blood vessel formation with chronic loss of blood. So anemia in of itself, can really be the referee in trying to sort out what's happening to a particular patient.
Yeah, but I would probably have a comment here because, well, ovarian cancer might not necessarily present with anemia, but doesn't that depend on the stage of the cancer? If you have a patient with an advanced stage, they may just present with an anemia that is not known. And after it's worked up, then you realize the patient has metastatic cancer, which happens in a lot of cases in my case.
Right. It's not all or none. And even in advanced stages, they may not be anemic, but it may not be anemia as it pertains to blood loss, right? There's also anemia of chronic disease, which you can probably explain better than I can. Because once you start having these issues, you have physiologic derangement that impacts on nutrition and your ability to want to eat the right things, and that also can affect the hemoglobin production.
Well, yes, and it has to do, well, if you're going to go into really detail, it has to also do with the with the production of erythropoietin from the liver and from the kidneys,
right.
Which essentially stimulates the bone marrow to produce more red blood cells. So that has to do with anemia of chronic disease also. I mean, it's a very complex interaction in terms of what the initial insult is in anemia. Sometimes the initial insult is one that is on the line, and then when a patient develops a condition, it really makes it worse. So when I get a patient that is sent to me for anemia, for just essentially a patient that is anemic, and the anemia is not known, there are lots of things we have to look at. You look at the sex of the patient. If it's a young female that is 35, she probably has, fibroids, she's probably bleeding. If it's a guy in his 80s and he has no cancer and no other condition, he probably has a condition where the bone marrow is not producing red blood cells enough. And sometimes in between that, you find a patient that has renal failure. It may have to do with the production of erythropoietin from the kidneys. So it's a complex, in lots of cases, anemia is just a presenting symptom or presenting condition. Essentially, you have to work the patient up to find out what started the anemia or where it came from.
Right.
All right. In the past, Omar.
Yes, Dr. Court.
In the past, we had discussed basically three categories of anemia. And I think sickle cell would fall into the class where the patient is destroying their blood cells, as opposed to the young lady that was that Dr. Anderson was talking about, where it's blood loss from the menses, and the older person where it's blood loss
GI tract.
from the GI tract, basically.
Right.
Yeah, well, and not just that. In terms of destruction of the red blood cells, not only sickle cell disease that can cause that in young females. You have young females have hemolysis. They have autoimmune hemolytic anemia. In some cases, because of lupus, because of other conditions, that they can just essentially destroy the blood cells, and it's called hemolysis. So there are many things you have to look at when you look at the CBC report itself. There are lots of things I look at to determine where I go, including the MCV and the MCH. But these things, I guess we won't talk about it now.
Right.
Yeah.
Anyone else?
Well, if I may add to that.
Go ahead, and then Dr. Sprott. Go ahead.
Right. So understanding that anemia is a very complex signs or symptoms of a background disease that's currently taking place. We need to understand a few things. That one, anemia can come either because the bone marrow is not producing enough, or that's been produced has been lost. In the case of sickle cell or other chronic diseases or severe malnutrition, you don't have enough of the components, like the protein and the iron and all the components that help you produce the anemia, produce the blood, because they're supposed to give those nutrients to the bone marrow and the liver to help you produce red blood cells. However, again, there may be intrinsic problems wrong with the bone marrow itself, like leukemia or other medical conditions that can inhibit the bone marrow from producing red blood cells or increase loss. Now, when it comes to sickle cell, one of the questions I've always been asked is, and one, especially for those of African descent, why do I have to have this? Why is this disease bothering me? I mean, giving a historical anthropological explanation for that has been tied to malaria as a way of protecting those of African descent and those back home, because even till today, malaria is one of the leading causes of death in kids, 4 years or below. So I guess nature is finding a way to, sustain man, sustain humanity. DNA modification took place, and that's why again we come up with using the word epigenetics, in the sense that the environment and everything around you tend to alter how your DNA expresses itself phenotypically. So again, this is the things that we have to go, as we go.
Well, they happen because they were born with it.
Yeah.
Dr. Louis, can you really explain to me how does sickling help prevent malaria or help in the treatment of malaria? What happens? What does it produce? Does it increase the red blood cells, or does it prevent sickling?
Well, again, if you understand, I'll take it this way. For you to have red blood cell, that's the cell that carries oxygen within the blood itself. There's a heme component, which is the iron component, which you need it, and then there's a globin component. That's why it's called hemoglobin. So a combination of both help you to attain producing red blood cells from the bone marrow. Now, just like Dr. Trevor Lay had said earlier on, that you're born with it. You're born with it because the natural red blood cell that's normal is oval in shape. Oval because it needs to meander through the pipes, the vessels, as they carry oxygen. So they're malleable as they move around. Now in sickle cell, they're ellipsoid or sickled in shape. And because they're sickled in shape, it's hard for them to pass through. The question is, why are they sickled in shape? Now, in the components, I want to break it down. In the process of being produced, some of the structures of the DNA, right, of the structure that forms the wall of the cell, undergoes some changes that crystallizes some components of that cell, and that's why they get sickled. And a sickled cell that's sickled like that is hard. It's not as malleable and easy to navigate the blood cells. So again, if you look at it, not wanting to go too details, in an elemental form of it, but the crystallization of the components that create the sickling is one of the ways why this happens. Now, malaria has been shown to do that in the sense that a cell that's sickled like that cannot take up the malaria parasite. So if it can't take up the malaria parasite, it cannot transmit the malaria parasite. And we often think that it's only the malaria itself that kills. Malaria can go to the brain and you have cerebral malaria. Malaria goes to the kidney, it causes nephrotic syndrome and kidney failure. So those are some of the things how it really does create.
You answered my question, Nelson.
Dr. Court, can we ask? I asked Dr. Kendall Sprock to go ahead.
But Nelson answered my question.
Yes, go ahead. I thought he did, but go ahead. Nelson.
He said that it can't attach to the cell.
Yeah, it doesn't attach because it's a harder cell. The outer shell of the red blood cell is harder and it cannot attach.
Well, I mean, do you want to,
Dr. Sprock?
Okay.
Yeah, the way I approach things is sort of looking at what is normal and what's the normal process.
And when you're talking about anemia, you're talking about a low hemoglobin concentration, and hemoglobin is sort of measured in grams per 100 cc's. But almost any step in the production of the red blood cell can have a problem and result in decreased production of hemoglobin. Now, when you're talking about the second component is the destruction. The normal destruction of the red cell occurs because of its shape. Dr. Lane talked about the normal shape, and the normal lifespan of a red blood cell is about 120 days. Sure. And as it ages, it tends to lose its shape. And one of the places that it's destroyed, or the major places, in the spleen. And there's sort of a network of a pathway that the red blood cell has to bend in order to get through the spleen. And as it changes its shape, it starts to get destroyed. So that the major reason that cells or red blood cells are destroyed is based upon its shape. And as was spoken before, because of the abnormal type of hemoglobin, sickle, it makes that red cell sickle, and so it doesn't survive as long. It may, instead of living 120 days, it might live only 30 days. And so the survival time of the red blood cell is short. And because they're destroyed, almost all the things that you need to make it are still present. And so there's a higher rate of production of red blood cells. And so if you look at on a blood smear, you might see a large number of young red cells, but the total amount of hemoglobin is very, very low. And so part of the issue, and although you're born with a genetic defect, you don't actually are born with sickle cell, because the major form of hemoglobin at birth is called fetal hemoglobin. Sure. And fetal hemoglobin, the amount of fetal hemoglobin that you make, is sometimes offers protection against sickling. So there are some individuals that have SS disease or sickle cell disease. If they have a high amount of fetal hemoglobin, they don't have the number or the amount of sickling or the severity of sickling as someone that might have very low amounts of fetal hemoglobin. And some of the treatments are designed to try and increase the amount of fetal hemoglobin to decrease the sickling. And as we said before, there's either decreased production, and you can look at anything along that line that looks at the production, including the bone marrow, the amount of iron you take, the transport of the iron, the release of the iron. And then the other thing is loss. And the major source of loss is usually from the GI tract, where you might do a blood smear. When you're talking about hypoxia, the definition of hypoxia is really an inadequate amount of oxygen utilization at the cellular level. Mm-hmm. And the usual reason for hypoxia is there's not enough delivery of oxygen there. And that might be because there's not enough hemoglobin. It might be because you're not breathing enough oxygen. But it's that, and indeed, when the cells don't get enough oxygen, they start to produce acid. And so if someone is hypoxic, they usually have an increased amount of acid in their body. Now, someone can become hypoxemic if they're not breathing enough oxygen and their oxygen concentration goes down. But folks that have anemia are not hypoxemic, but they can be hypoxic because of a decreased amount of hemoglobin, there's not enough oxygen delivered, and the patient then starts to undergo that acidosis. Okay. You have very low blood pressure, you can be hypoxic. So there are a lot of reasons for hypoxia, but not necessarily related to anemia.
Right. Dr. Lane, there are a lot of questions coming in. And but if you want to expand on that, go ahead, and then I want to get to some of the questions coming in, because a lot of the questions are coming in.
No, I think that with as the doctors were saying, with sickle cell disease, with SS disease, mm-hmm. and with the pain caused from sickle cell disease, we have to understand that there are two types of pain with sickle cell disease. There is acute pain mm-hmm. caused by hypoxemia, ischemia, and inflammation, and then there's chronic pain, caused by, for example, necrosis of the bone marrow, osteonecrosis, and infarcts, which is as a result of chronic ischemia. So, also with sickle cell disease, patients will have an acute episode on top of a chronic condition, and usually they're both, they have to be treated separately. What the doctor was saying about hemoglobin F is actually pretty accurate. The fetal hemoglobin, because fetal hemoglobin, it moves the oxygen dissociation curve to the left. It hangs on to oxygen a lot, hemoglobin F. This is the reason why on a plane, they would tell you, put your mask on before the kid's mask on. And you would think it's funny, but you're going to die before the child because the child has more hemoglobin F that holds onto oxygen much stronger than your adult hemoglobin. So it's just something I wanted to explain. Yeah. And the drugs that we use for sickle cell disease, hydroxyurea, how hydroxyurea works is that it is a chemotherapy drug, but it increases the concentration of hemoglobin F. This is the reason why it's used routinely.
Right. Let me get to some of the questions that's coming in. One question is from Ray. He says, I have been diagnosed with anemia. Can you recommend some holistic treatments? Are there any holistic treatments that you know or you've come across, Dr. Lane, or tell us, if you can?
Well, it depends on how old this gentleman is and what is the reason for his anemia. But I think that generally, with lots of patients of mine under the age of 60, where they're sort of, as I explained to the patient, where the bone marrow sort of becomes lazy and hematopoiesis is not as active as it is when they're younger, there was about 3 or 4 studies that showed that the omega-3 fatty acids does work. It increases or it optimizes the bone marrow milieu to form red blood cells. So I use lots of omega-3 fatty acids in those patients, quinol or fish oils, and I just use multivitamins. That's what I tend to use in those patients.
All right. Okay. And also, go ahead. I'm sorry.
I was just going to say, Elaine, a lot of those holistic patients tend to be vegetarian. And do you tend to more anemia in vegetarians because they're
they have because a lot of people don't realize that B12 is important. Meat is important for B12. So you find that a lot of them have B12 deficiency,
right.
And in fact, some of them have sort of pernicious anemia with the beefy red tongue. I've seen those before. So I think they have to realize that B12 is an important part of the formation of red blood cells also. So usually find themselves with B12 deficiency.
Okay. Yeah. The question came in about diabetes type 2. Is anemia associated with diabetes type 2?
It's a question that I've been asked since we were in doing my fellowship. We are of the belief that at the cellular level, diabetes is an inflammatory condition, because we find that patients, for no other reason, just because of diabetes, even if they don't have renal failure as yet, they're anemic. So, we think that there is an inflammatory process at the cellular level of diabetes that causes, in some cases, the decreased production of erythropoietin. So it is something that is in the literature, and it is something that is possible, that it is at the cellular level an inflammatory condition causing decreased erythropoietin and causing by itself an anemia of chronic disease that is separate from renal failure itself.
All right.
Let me add to that a little bit.
All righty, please. Yes, go ahead.
Because one of the questions, I think over 20 years ago, I asked a renowned nephrologist in the sense that when do you start the medications that protect your kidneys for those who have diabetes? Because number 1 cause of kidney failure in the world is diabetes. Number 2 is high blood pressure. So if you have a combination of both, that's a double whammy, I always call it. Now, and I asked that question for a reason. Do you wait for the protein to come out when you see it in urine before you start, or you start once you diagnose them? Now, understanding that in this country, in the United States, it takes an average 5 years from diagnosis to complete control of diabetes, which is a shame. And that's why we often see the amount of people who have complications of diabetes. So, and that's why in 2013 onwards, where they came up with the description of pre-diabetes, meaning there are people who have diabetes, but without manifestation yet. And those people will classify as pre-diabetes. So they're pre-diabetic. Now, studies have shown 40% within the next 5 years will become diabetic. Now, the question is this: those who are pre-diabetic, do they have issues going on in the vessels already? Because diabetes affects both big vessels and small vessels, which are called the microvascular vessels. So the microvascular changes of diabetes actually do begin a longer before you actually begin to diagnose them with diabetes. So if you are pre-diabetic, the microvascular changes may actually be taking place. Now, if you flip that on a full circle to the kidney, understanding that the kidney is paramount in producing red blood cell. And that's where the juxtaglomerular complex, which is right in the kidney where the erythropoietins help, matures, has a way. So from pre-diabetic stage, those microvascular changes that supply the unique vessels in the kidney actually begin to change already. So that's how all of this begin to take place.
All right. All right. Thank you. Who was that?
Saying that once a patient is diagnosed with pre-diabetes, that patient automatically will develop full-blown diabetes later?
Dr. Aluya, from my understanding, Dr. Court, pre-diabetes with with exercise and appropriate care is curable, and that's what the literature states. Now,
but Dr. Aluya says something else.
All right, there's a difference in opinion, I understand, but that's
I don't think Dr. Aluya said that it was a foregone conclusion.
No, but
right.
For a couple of years
proceed. And just one other thing that
go ahead, Dr. Sprout.
Yeah, just the question that was asked earlier, is there any natural way? There have been some studies that suggest that echinacea might be a boost to the production of erythropoietin. And some people who are long distance racers or run races take echinacea to try and decrease the oxygen consumption of muscles. So there's some thoughts of belief that that might be the case.
Okay. There was another question that came in, and this is from Jeremy. I was anemic when I was a child. Is there a way to overcome that?
Is there a way to overcome it?
Yeah, that's what he stated. Now, hopefully, we can interpret what he means by that.
Yeah, I mean, I don't know exactly what he means, but there are some conditions where it could be anemic as a child, like lead poisoning. Where probably you're moved and or increased lead consumption, or you're moved and it resolved itself, because lead poisoning can give you microcytic anemia itself.
Right.
So it may be something like that, or it may be that he had a hemolytic process as a child, which at times they would have hemolytic syndrome in childhood that could resolve itself as you get older. It may be.
Right. Let me ask another question. This is a question that came in on prostate disease. Does saw malpito extract, I probably messed up that, and cranberry juice have any benefit on prevention of prostate cancer? Is it?
Not that I know of. What is what?
Palmetto.
It's
Palmetto.
Saw palmetto.
It's a
plant product.
In the prevention of prostate cancer, I don't know. I won't think so.
All righty. Dr. Anderson, you were going to say something?
Yeah, I think things like saw palmetto and cranberry extract has to do with their plant sterols and their potent anti-inflammatory agents. So those products, and you see them advertised all the time, I think they work through decreasing prostatic inflammation. With respect to preventing prostate cancer, I'm not sure that they've been proven, but certainly they can help with some symptomatic relief of some symptom related to the prostate.
Yeah, but there have been studies where chronic inflammation can induce cancerous process in the prostate also. And that's why we use all the zinc also, right? Because it has something to do with the immune system and anti-inflammatory effect also.
All right. There was go ahead, I'm sorry.
Cranberry juice reduces risk of urinary tract infection.
Right, we do know that it changes the pH.
It acidifies
All righty. There was another question about prostate. I have prostate cancer. Tell me about it. Prevention, diagnosis. He wants to know everything. Prognosis, and what's the best treatment? Okay, can you just give us, since I know black males, this is the thing for black males. Can you give us kind of some understanding about prostate cancer since we have you?
Are you talking to me?
Yes, Dr. Lane.
Well, it is the #1 cancer in men. It's not the #1 cause of death, but it's the #1 cancer in men. It's the causes of prostate cancer are varied, but I think that what we see most is a correlation in terms of family involvement and family history. Some of the inflammatory things we talk about, and of course, you have the BRCA gene that can do that. So there are lots of different reasons for it. Now, in terms of how you deal with prostate cancer, what makes a difference is how soon it's diagnosed or how early it's diagnosed. And this is why it's important that men go and have the physical examination and have their PSA checked on a regular basis, because the earlier diagnosed prostate cancer, the better your survival. In fact, once the cancer has not gotten through the capsule, it's essentially curable these days with robotic surgery. And so I think that we stage prostate cancer as stage 1, 2, 3, and 4. Stage 1 and 2 essentially is if it's really in the prostate itself, it hasn't gone through the capsule. Stage 3 is when it involves the capsule and involves the lymph nodes. And stage 4 is when it spreads to the bones or spreads to the organ system. Mm-hmm. Prostate cancer tends to spread to the bones very easily because of the Batson's vein. So it spreads to the bones and the vertebrae very, very easily. So essentially stage 1 and stage 2 is essentially curable with surgery. Stage 3 and stage 4 is long-term survival. I don't believe personally that any man now should be dying from prostate cancer, because if you have your PSA checked, if you go to your doctor on a regular basis and you do what the doctor tells you in terms of, if you should have surgery, if you should have radiation and all that stuff, you should not die from prostate cancer. There are lots and lots of different drugs now used for prostate cancer as compared to where we were 10, 20, 30 years ago. I mean, there's lots of good hormonal therapy that is used. And I think that the answer to the guy's question is essentially what's the stage of his prostate cancer and how long has he had it. That's what I need to know in order to prognosticate his survival, or what he will do.
Right. Well, thank you. Anybody else want to chime in on that, since we're dealing with prostate and it's a major problem with African-American, Black and brown men? All right.
As a primary care physician, I always, especially if you're coming to see me for the first time, I always will, if you're a Black male, or if you're male generally, one of the very first tests that I will also ask for is the PSA.
Right.
Mm-hmm. Very common, especially in African Americans, of those of African descent. But then it's also, manageable if it's caught on time. So
right.
Go to the doctor, ask to get tested.
All righty. There's another question that came in. I am a breast cancer survivor.
Trevor, Omar, I just want to add one thing. That I think
sure. Go ahead.
I want to add one thing. I'm sorry, I was muted. My experience, I recently went to my primary care doctor and she did an exam and everything. And as a man over 50, one of the most important things is a rectal exam, besides the PSA, rectal. Right. And my primary care did not perform that until I said, so aren't you going to do a rectal? I know it's uncomfortable. I know we got feelings about it, but it's something that must be done. And you must, if your physician doesn't do it, you must alert them to do a rectal exam.
Right. Agreed.
And most Black men have to get over the whole thing about, homosexuality when somebody puts their finger up in there. It's not because we enjoy it, it's because we have to do it.
Right. All righty. Thank you. This is a question about breast cancer. I'm a breast cancer survivor. Let the women know how important it is to have a mammogram, number one, when they should start, when they should first get their mammograms, and how frequently they should get mammograms.
I think we should get Dr. Kevin Clark in here.
Dr. Clark.
Sure. Well, the issue is not when they should get a mammogram. If you've already been diagnosed with breast cancer, you're now in the phase of what we call surveillance. So you're no longer being screened. You're being evaluated for either recurrent disease or for new diagnosis in the contralateral breast. So typically, your surveillance pattern depends on the stage of the cancer. So you should see your oncologist every 3 to 6 months. Imaging, as far as mammograms, you probably don't need to get it more than just yearly, unless there's some abnormality that's being evaluated or followed. But really, you're not in the phase of just regular screening. You're in the phase now of surveillance. So as a cancer patient, it's more intense than just regular screening.
So Dr. Clark, as a point of personal privilege, In terms of the regular screening, right? I mean, mammograms, I have seen lots of patients, probably about 4 or 5 in the past couple of months, where the mammogram completely missed the cancer. I mean, are we thinking now that since there is an increased incidence of dense breast, I believe, among women, that we do more ultrasounds and MRIs of the breast instead of mammograms? How do you feel about that?
So the issue with lesions being missed has to do with breast density and also the ability of the radiologist, right? So there are different components of why something's missed. In cases where it's difficult to pick up on a mammogram, it's usually cases where it's younger patients because they typically have more dense breasts, or women who have large breasts or dense breasts, because that's the condition or the situation where you can miss a small lesion. Now, what usually happens is that you should get reflexively, they should order an ultrasound in difficult cases where it's hard to interpret the mammogram. So in cases where it's not clear cut, the radiologist usually automatically orders a diagnostic ultrasound to have better resolution. Those two things usually should give you a good sense of what's going on. If you can't figure it out with a mammogram and an ultrasound, then that's when you would get something more sensitive or more complicated, like a breast MRI. But again, you should always start off with the mammogram. If the mammogram is equivocal or non-diagnostic, you'll add an ultrasound as a balance. And if you can't resolve it with those two, then that's when you go on to a breast MRI.
How about in men?
Dr. Clark.
How about in men?
In men, breast cancer usually it's usually not subtle. So it's usually a palpable mass or nipple irritation. You get your standard mammogram. You really don't need more fancy or additional tests to make the diagnosis. So usually just a mammogram would suffice, but it's mostly going to be a clinical diagnosis in men, because the majority of the time they're going to present with some symptom. We don't screen men for breast cancer. There's maybe, I would say, very specific cases. So if you have a family history of BRCA2, that increases your risk of breast cancer. So those men, you can argue, should be screened. But again, we typically don't do screening mammograms in men.
So just as a devil's advocate here, Kevin, we know cancer is basically a genetic disease. I mean, all cancers are a genetic disease. And we now know that the BRCA gene does play a role in a subset of men with prostate cancer. And if prostate cancer is so prevalent among Black men, what do you say with respect to screening for breast cancer in Black men?
Yeah, that's going to be my question. Well, yeah, I don't know. It's something that we probably have to sort of advocate more for.
Well, remember though, to screen, it has to be both a high-risk population and a prevalent disease. And again,
prostate.
You look at male breast, right? Prostate is, when you look at male breast cancer, you're talking about 1% of all breast cancers. So really, the value in screening men would be very low. And it's a disease, for the most part. Breast cancer is a curable disease. When we talk about pancreatic cancer, which patients with BRCA mutations get, that's another issue that you could argue that those patients should be actively screened for pancreatic cancer.
Yeah, but we're talking about men with known prostate cancer. So that in of itself has created its own high-risk group. So should we be looking at men with a history of prostate cancer differently? Because I think it would be a little bit of I guess hypocrisy is a strong word to say, well, women with certain personal history of cancer, especially gynecologic cancer, now you start to pay attention to screening for breast because they could be part of a cancer syndrome. So we send many patients. In fact, today I struggle with finding a group of women either with a family history or a personal history of any cancer who should not be recommended to have genetic screening.
Mhm.
So if we do that for women with personal history of certain cancers, then should we not be saying the same thing to men? You know, because again, in my head, because of our anatomy, when men get breast cancer, typically it's a higher risk for local spread because of the lack of breast tissue and adipose tissue in the male breast.
It's an interesting argument. It'd be difficult, not so much difficult to institute, but if you don't have breasts, it's hard to do a mammogram.
Yeah.
So you'd probably have to have some other screening modality besides a mammogram, and that would have to be validated. Because again, the majority of cases present symptomatically.
Right.
And even if you take the cohort of patients who have prostate cancer, and you separate that group, or you compare them to men who get breast cancer, I'm not sure there's a statistically significant difference in terms of both of those groups.
I have a burning question, Omar.
Yeah.
I'm frequently asked by patients, Dr. Cord, I need a mammogram. What's the current recommendations in terms of a patient who doesn't have a family history, but is coming to see me for the first time? At what age should we start doing mammograms? Because I think they go back and forth. It's 40 or is it 35? What's the current recommendation for?
And the current recommendation is going to change. So it goes back and forth. I think it's safe. It's safe to start at 40 and do it every year. There are recommendations where you say you do it every other year. I don't think you're wrong at starting at 40. I think, again, this isn't the average risk woman without a family history.
But Dr. Clark, can I just make an argument here? The initial study that was done that made the age of 50 that we all grew up with, right, was a Swiss study. It was in white women. Is there a difference that you think it should start earlier in black women at the age of 40 or something like that? That's what I tell my patients, that they should start at 40.
So
Mine also 40.
So all the mammogram screening studies are I won't say that they're poor, but there's not a strong conclusion when you take all the studies into consideration. The issue is the majority of patients who get breast cancer, it's going to be in the 50 to 70 age group. That's the highest incidence. If you start at 40, yes, you will pick up you'll pick up some more breast cancer in that group. But again, the highest risk group in general, without a family history or any high risk features, is going to be in the 50 to 70 age group.
Can I ask a question about the?
All right, hold on. Dr. Atherley's next.
Yeah, I want to ask a question about the presentation. I mean, obviously, part of my business is to take care of chest pain. And many females, when they come to me with chest pain, and I assure them that the heart is fine, etc., well, the next organ they may naturally think of is the breast right there. So is there any evidence that cancers of the breast can ever present with chest pain in the absence of an easily palpable mass that they themselves will recognize? Is there any point? They ask me, well, should I get a mammogram, etc.? I generally do not recommend that because of the chest pain. Is there any indication or any reason why they should, if they're having pain that I've ruled out as being cardiac in origin?
So most cases of breast cancer are not associated with pain.
Right.
That's the first thing. If they're of the appropriate age where it would get screened anyway, then I would institute whatever screening protocol is appropriate for that age. But if you have a 30-year-old who comes in with chest pain, and you've ruled out, for whatever reason, any cardiac cause, and she has breast pain, that probably is related to fibrocystic changes. Now, you never wanted us to assume. I think she should still go through and have a history physical examination. And if there's something on exam, she should have the radiologic workup. But in general, breast pain and cancer are not associated. Certain cancers do present with breast pain, but clinically, those are the ones that are very large. They're typically large, and they're typically locally advanced, or they usually involve the skin or the underlying structures.
Yeah, because I think inflammatory breast cancer doesn't necessarily have to present with that. At times, they present only with pain in the chest because of the inflammation. I've seen that.
Yeah,
Right,
I think though, with respect to
so-
screening,
Yeah.
with respect to screening, it's not one shoe that fits all. I think, you know, part of what we do, especially, and my specialty, often we're in a situation where we're also considered primary care, is each patient you see, you establish a risk assessment for specific things that we're concerned about. And I think with respect to breast cancer, as a risk assessment, as it pertains to family history of cancer, and you can start with any cancer and then narrow it to specific cancer syndrome, both in males and female relatives, first and second degree in the family. And then that may key you in to make recommendations for screening or diagnostic testing based on symptom for individual patients.
Right.
Alrighty. You know, the thing of it is, let me get to, I want to jump back to prostate just for a minute, because we have a few prostate questions that came up. What is the normal PSA? Can we get a normal PSA?
It's between 0 and 4.
Between 0 and 4. Okay. And
But Omar,
go ahead. Can we expand on that a little bit? Go ahead, Dr. Sprock.
one of the things that Dr. Lang commented on related to breast cancer applies to PSA screening. Most of the studies done on PSA screening were not done on African-American men. And there's been some controversy about whether or not PSA ought to be continued to be used or is a gold standard, because there's a certain normal level of PSA. When I went to for my annual exam, I've always had low PSAs. My primary care doctor says, you know, it's not necessarily recommended for you to continue to get PSA. So there is some controversy there. And it goes back to what Jordan said earlier, is the digital exam is very important. Another aspect of that talked about, Dr. Clark commented on, about mammography and folks missing the diagnosis. One of the things that is increasingly becoming important is the use of artificial intelligence to review both radiologic diagnosis as well as pathology, because they're developing these algorithms that the computer can diagnose things a lot better than radiologists. And so that may be some of the answer to what may happen in terms of how things get diagnosed going forward.
Right.
Yeah. And if I might comment too, and this goes back to the issue with prostate, I think, again, one has to identify and create a risk assessment for individuals, but 0 to 4 is meaningful. But I also think the absolute number may just be give us a false sense of security. I think if you have serial values, even if they're within the normal range and there's a progressive rise, especially if they change by a certain percentage over a short period of time, that may have significant implication.
It's got a velocity. If there's a velocity, yeah, absolutely.
All righty.
Can Omar, can I just weigh in on this whole?
Yeah, you sure may. Yes.
You know, the recommendations for mammogram, but I even want to dial it back even more so, just like Dr. Sprott talked about, physical exam. Because you get an initial mammogram, one of the problems we have in our community is early diagnosis, because we don't go back to the doctor. Because you have an initial mammogram that is normal, an initial PSA or initial rectal exam that is normal, doesn't mean that you should stop going. We should continue to advocate for our patients to develop a relationship with their primary care doctor and to continue to go back to that doctor on a regular basis. You know, 5-year intervals, the time from a breast cancer to go from a stage 0 to a stage 3 in 5 years is very, very high. But the incidence of going from a stage 1 to a stage 2 or stage 0 to a stage 1 in 2 years, it is imperative that you go back and have a follow-up, and the differences in survival rates for early detection in breast cancer. You're talking about a 90 to 95% survival rate for early detection, even if your initial mammogram is negative. If you go back and have another mammogram within 2 years, which is recommended, or 1 year, something that can be caught and be treated adequately. Same thing with prostate health, that we should have our yearly annual physical, and all these things, cardiac disease, diabetes, thyroid disease, all these things can be picked up early if we continue to go back to our primary.
Dr. May, if I may ask, say 1 or 2 things and then ask a question, as a matter of fact. 2 things. In the realm of breast cancer, I've seen in younger and younger women in their 30s with breast cancer. I've seen a lot of them because I helped run a primary care cancer center at the university, and I was shocked to see this number. And then when it comes to prostate cancer, again, you know, they coming younger and younger as compared to what it used to be. And unfortunately, we've seen a lot of them that are very, very aggressive, just like you see very aggressive cases of breast cancer in women as well. Now, in terms of screening, the question is this. Once you screen and the number, like Dr. Lane said, 0 to 4 is what you see. But sometimes you may have a little bump up to 6 or 8 as we go older, especially, you know, as we develop, men develop benign prostatic hypertrophy, which is the BPH, which is the normal process of men as we grow older. But then underneath, you never can tell if there's cancer. So a bump of 6 to 8 to 10 for individuals who do have that, in my office, I will repeat that again in 3 months and see if it stays the same, and to ensure that, you know, there's no UTI going on, because the inflammatory process can bump the PSA up as well. Now, if it comes down within 3 months, then, you know, you can say, okay, fine, you can, you know, screen again in 6 months. But if there's an increase, then you need to, you know, screen again in another 3 months, but then refer to a urologist. Because just the number of 8 to 10 in most cases of prostate cancer, they, you know, really high. But then we've seen cases where it's just 7 or 8, and then it's almost metastatic cancer, so prostate cancer. So we need to take this into cognizance. Now, in terms of black men have a very high incidence of prostate cancer. Now, if you take all black men across the globe, this is a question for anybody on the panel. Have you seen any ethnic groups or people of certain countries who present with higher incidence of prostate cancer as compared to other people? Because some people have said something about those of the Caribbean, especially the Jamaican, you know, ancestry, tend to have high incidence. I don't know if that's the truth with your experience.
Can
well,
someone,
you know, Nelson, you know, you got to call a leper. You know, I can tell you countless men from the Caribbean, Guyana, Jamaica, some of them very young. I've known people dead at age 58, 6 months after they've been diagnosed. And I've also known men with not advanced disease. You know, we talk about stage, but stage is one thing. Virulence is another aspect of cancer. And Dr. Lane can chime in on this. Each person's cancer, even if it's the same, 2 individuals with the same cancer, same stage, the individual disease may have its own intrinsic biology, right? I've known individuals whose PSA got to 4, but it went 2.2, 2.5, 2.6 to 4, and has prostate cancer that, based on the location, not the size or the amount, but based on the location of the gland, that disease violated the capsule. That in of itself, even though it's an early stage and may be classified as even high intermediate risk, when you do scores, additional studies, and develop these scores like the Decipher scores, it ultimately put them at 30, 35% risk of recurrence. And in medicine, anything that high is significant. And this is an early stage disease. So again, individuals' intrinsic biology of their disease typically would make a difference.
Oh yeah, that's absolutely true. I mean, in prostate cancer, you look at the Gleason score. And when you look at a pathology report, we look at if it's well differentiated, intermediately differentiated, or poorly differentiated. Poorly differentiated cancer, the PSA could be, you know, 5, 6, 7, and it could be metastatic.
Dr.
So
Lane,
it depends on the cancer characteristics.
Explain differentiation. Most people don't know what that means.
Well, it depends on how well formed the cells are. When the pathologist looks at the cells under the microscope, if you can see a demarcation in between cells very well, that's a well-differentiated tumor. If you really cannot, and it looks all jumbled, it means that it is a poorly differentiated and fast-growing tumor. So the differentiation is seen on the pathology report. And you know, if you look at some of the pathology report, they will say, you know, there's a low mitotic index, or there's a, you know, high mitotic index. A high mitotic index usually indicates poorly differentiated tumors. And a low mitotic index usually indicate well-differentiated tumors. So that is done by the pathologist. So and that tells you, I've seen patients with a 3-centimeter breast mass, and there's mets all over the place, and there are patients with 8-centimeter tumors, and they're fine. They have no mets. So it depends on the intrinsic characteristics of the tumor. Dr. Anderson is absolutely correct.
Right. How aggressive the tumor is. Right.
Yeah.
So Nelson, what you mentioned, alluded to the young patients and the patients who present with, as Dr. Anderson put it, very virulent disease is one of the difficulties that we have, because you can't apply the regular screening algorithm to these patients because they won't fit. So the 30-year-old who comes in with a palpable mass, again, depending on what the clinical features show, that should be a fibroadenoma, not an advanced breast cancer. But yes, we have seen those patients, and you have to now put that into context. So the history, the physical examination is, as Dr. Garrison alluded to, and you can get mammograms in young women. It has to do with whether or not they fit the profile of having a breast cancer. So typically, it's not the immediate test that you would get in a 30-year-old, but a 30-year-old who presents with the appropriate physical examination that's concerning for cancer, yes, you will get that algorithm. Now, it's one of the things that we are trying to sort of figure out if you could go back in time and say, well, is there anything in this particular patient or group that we could have figured out to test them ahead of time to pick this up early? And without having some idea of family history, that's really the mainstay of our ability to go back and figure it out. The screening tests that we have, I can tell you, we see a lot of what we call interval cancers. So these are cancers that pop up in between mammograms. And they're interval cancers because they grow very fast. So you'll have a mammogram last year, and then in between the time when you're supposed to get your next mammogram, they'll come into the office complaining of a palpable mass. And it's not that they
palpable mass, Kevin.
Palpable mass means that you can feel it on exam. So it's something that you can feel as opposed to actually seeing on imaging. And it's not so much that they missed it on the previous imaging, but it's just a very fast growing tumor. Same thing with the colonoscopies. There's the age that we're starting now is 45. It used to be 50. Again, in between a normal colonoscopy, it's supposed to be 10 years. If you have a normal colonoscopy, your next one should be in 10 years. There are different types of polyps that we know now, and there are different ways patients get colon cancer. And that interval actually may not be appropriate because the different types of polyps people get, it's not a 10-year interval that it's going to grow. It's a much shorter period. So there are limitations to screening that we're beginning to find out, and there are different screening modalities I think we're going to have to use based on more information as we get it.
And one of the important things is when you talked about the palpable mass is the self-examination. Dr. Luya is med-peds, so he takes care of adolescents, and teenage girls should be taught how to do self-examinations when they take their showers. And that becomes very, very important. That's something that they can do in the intervals before they even start to get mammograms and between the mammograms. Because very often if they do it on a routine basis, they may be able to pick up something that wasn't there before and therefore get treatment.
All right, guys.
Dr. Luya, if you don't mind, not to overburden this, but this is something that happens often enough. And just like Dr. Spratt had just said, teenagers, adolescents, the issue of birth control pills and breast cancer. What's your take on that? And if you guys can say something, because there's a huge, strong correlation somewhat with those who take birth control pills and for a certain number of years, and if you need to be off it for a washout years or something like that, and if there's any relationship with breast cancer.
All right.
I don't know.
Patrick, can we hold that question? Can you remember your answers on that question? It's halftime. I just have to take care of a little business here. Give me a moment.
Okay.
Give me a moment. But we're going to hold that question and we will answer that question. Dr. Luya, make sure we answer that question, okay? you know, it's halftime. I just want to say, let us do this. I want to reintroduce a lot of all of the doctors. First, I would like to, Dr. Alfred Davis is joining us. Can you unmute? First, I would like to let Dr. Alfred Davis introduce himself, and then we're going to all quickly reintroduce ourselves. The reason we do that is because obviously there are people that joined and may not know who everyone is. Dr. Davis just came off. So we will start with Dr. Atherley real quick. Let's reintroduce ourselves.
Trevor Atherley, I'm an interventional cardiologist. That's a cardiologist who uses tubes and diagnoses and treats diseases of the heart. In addition, I'm a general cardiologist, and I'm also a member of the teaching faculty at Newark Beth Israel Medical Center. My main practice is in Newark itself.
Dr. Ken Sprott.
Kenny Sprott, I'm a pediatrician, background in general pediatrics and critical care pediatrics.
All righty. Dr. Nelson Aluya.
Well, medicine pediatrics trained, assistant professor of medicine, Newark, New Jersey Medical School here in Newark, New Jersey. I call myself a medical advocate for good health everywhere.
All righty. Dr. Patrick Anderson, please.
Yes, Patrick Anderson. I'm a GYN oncologist at Beth Israel Medical Center. Take care of women with cancers of the female genital tract.
All righty. Dr. Kevin Clark, please.
Well, Dr. Kevin Clark, a surgical oncologist. I work at the Newark Beth Israel.
All righty. Dr. Trevor Lane.
It's Trevor Lane, medical oncology, hematology, working out of Newark Beth Israel and St. Barnabas Medical Center.
All right. Dr. James Court.
Dr. Court, internal medicine. I treat adults, no surgery, no kids.
All righty. And Dr. Alfred Davis, thanks for joining us. Dr. Davis, can you hear us?
Yes, thank you. Yes, thank you for having me. Dr. Alfred Davis Jr., Davis Integrated Medicine in Montclair, New Jersey. I am a chiropractor. We have physical therapy, acupuncture in our office. We have a nurse practitioner, and we also have a massage therapist. Thank you.
Excellent. Dr. Fredericks, Dwayne Fredericks.
Dr. Dwayne Fredericks, bariatric surgeon. I specialize in obesity medicine. I work in South Orange now.
All righty. Thank you. Thank you. And Dr. Jordan Garrison, please.
Jordan Garrison here, general surgeon, specialized in bariatric and venous disorders.
All righty. And I apologize, I did not introduce myself at the beginning. I'm Dr. Omar Bey, pulmonary critical care with a specialty in nutrition. I would just like to thank our sponsor, OBHealthy. Let me just tell you a little bit about them. They're a weight loss product and have a weight loss app. They deal with culture-specific meal plans, dealing with health as well as weight loss. Losing weight with the food you love, they state, and they say soul food, Caribbean, Latin, vegetarian, and more. So it's a 14-day free trial, so you can just go to your app store, download the app, and see how easy weight loss can be. That's what they tell us. So, all righty, thank you. Continuing, do not change any aspect of your medical care until you consult your physician. This is so important. So I just want to drill that in. We are answering a lot of questions here. We're doing a lot of education, but do not change any aspect of your medical care before you consult your physician. All righty, we're going to continue. Dr. Aluya, that question, and Dr. Patrick Anderson, you were getting ready to answer it. Can we continue? And understand that we have a lot of questions, so I'm going to try to let's try to wrap each question up because there's so many questions we haven't answered yet. Dr. Patrick Anderson.
Yeah, so to answer Nelson's question, the WHO once put out a statement that the risk of breast cancer among women who have been past users or recent users of oral contraceptives is about 7%. From what I recall, there was an article, I believe it was back in 2017 in New England Journal of Medicine, looking at women who've taken hormonal contraceptives. And the relative risk there is about 1.2 to 1.3, which is a subtle increased risk. When you compare combination, which means estrogen plus progestin versus progestin-only pills, that data, as I understand it, is not very clear whether there is a risk. The risk is higher in the woman who takes the progestin-only pills. the reason that's an issue is we feel that in older patients, postmenopausal patients who've taken hormone replacement therapy, single agent estrogen versus combination with this estrogen and progestin, the breast cancer risk is higher in the progestin combination group. So even though the progestin is necessary to help decrease the risk of uterine cancer in women who have their uteri, that may cause an increased risk in breast cancer. So, so the parting message there is that the incidence of breast cancer in hormonal contraceptive use in the age group that is typically of concern is typically very low.
All right. All righty. Thank you. Let's go on. This is a question that came up from Candace. Good afternoon. I may need an ablation operation to clear up a problem of skipping heartbeats. That is almost twice the normal for skipping heartbeats in general. This procedure may be done through the groin to get to my heart. Is it dangerous? Is it a dangerous operation? Should I insist on other alternative treatments? Dr. Atherley, can you help us?
Yes. Well, let me first of all address the irregular heartbeats. When we identify irregular heartbeats, they might either be associated with symptoms that the patient is having at the time, or they may be associated with the potential lethal outcomes. Therefore, we assess the significance and the severity of these irregular heartbeats, and we use that to tailor how stringent the medication or the surgical or electrical intervention should be. So if you're found to have very bothersome or potentially severe irregularities, which are not easily controlled with medication, then there may be an electrical way to identify the location or the focus where these irregular beats are starting. Some of the assumptions may be that somewhere in the heart, there's an area that is electrically unstable, beating out of turn. It may either cause continued recurrent irregular beats or continued irregular beats for that matter. And that by getting in there with a tube, passing a tube up the groin area or the arm towards the heart and having an electrical current ablating or getting rid of or burning out that area of the irregular heartbeat may hence relieve you of the burden of those continued irregular heartbeats. So this electrical ablation is a commonly performed procedure, oftentimes for more significant arrhythmias. Generally, we try to control them with medication. In terms of the danger, the procedure is part of what is called cardiac catheterization. That is the ability to pass a tube, a catheter, through an area either in the groin or the arm, backwards through a vein or through an artery. So catheterization involves passing these catheters or tiny tubes back to the heart, and we record lots of things with cardiac catheterization. We record pressures, we can inject dye and take pictures of various areas, and we can also measure or record the electrical activity from various parts of the heart. So electrical ablation would then involve documentation or recording of electrical activity from certain parts of the heart, the determination that this activity is abnormal and may be a potential danger or discomfort to the patient, and then the recognition that we may get rid of these by passing strong electrical circuits or currents, or using other means, cryoablation with very cold tubes, etc. But there are ways in which we can ablate or remove these areas of irregular heartbeats or rapid heartbeats for the heart. Right. Can be done quite safely, risk very, very minimal.
Excellent, excellent. There's another question from Jeremy. Just had a seizure in my sleep last week. CAT scans came back normal, and now I need an MRI. Can somebody just expand on seizures a little bit, and if a CAT scan's negative, why we go to an MRI?
So I'll take off from what Trevor was talking about. So there are two different cells that sort of make electrical activity. Some of the cells in the heart and the brain cells. And so a seizure is an abnormal electrical discharge from the brain. And depending upon where the brain is, will determine what the seizure might present itself as. If it's in an area of the brain that controls your muscles or motor function, you might have jerking motor movements. If it's an area that controls your smell, you might have abnormal smells. And so I think that the CT scan was done, but one of the things that's done is to measure the electrical activity of the brain. Now, the problem with measurement of the electrical activity of the brain is if you aren't having a seizure, you might not be able to pick up that abnormal electrical activity. And therefore, sometimes they might want to do, like they do with the heart, is to take a long period of time over several days where they might measure what's going on to see whether or not you might have something. And sometimes they also do it with a camera to see exactly what your seizure is and how it correlates with the electrical activity of the brain. I think, you know, when you talk about the MRI and CT scans, they are sort of snapshots of pictures of the brain. They don't necessarily tell you whether or not there's any abnormal electrical activity or not. And so there are things that are done, but the thing that most commonly done is to look at trying to measure the electrical activity and pinpoint where in the brain it might be coming from. We don't know what triggers seizures. We don't know what triggers these arrhythmias. We know that they happen and we can measure them. And then we can also look at the drugs and whether or not the drugs might help take care of the seizures or not. But I think that in general, if you have a seizure, you should be seen by a neurologist who recommend the studies that are necessary to try and determine where it is and what might then be done.
Okay, excellent, excellent.
The other reason, one more.
Yeah, go ahead, Dr. Corey.
The other reason for the MRI would be sometimes in doing the CT scan, you do not pick up certain lesions, especially early. And these can be picked up with the MRI scan. That's probably the reason why they want to do it. Because
well, I don't know why they want to do it, but in general, most of the individuals that have seizure disorders don't have abnormal CT scans or MRIs.
Absolutely.
There's not a lesion that they see. A lot of the brain cancers don't typically present, and brain tumors in children is fairly common. They don't usually present with seizures.
They just want to rule out anything else. In this era where people get sued for missing things, so they'll cover your bases. So.
Right. Yeah. Excellent. The next question. I have always heard that people from the Caribbean are more predisposed to developing glaucoma. Is there any truth to this? If so, and why? Can anybody help us out with that one? Or are we all over our head as far as that was concerned?
You're all over our heads.
All right. All right. We will move on. All right. I have thyroid. I'm 50 years old and should take care of my, hold on, get an understanding of this. Hold on. I have thyroid. I'm 50 years old. Should take care of myself any different than, should I take care of myself any different than when I was 30 years old? Can anybody approach thyroid for us? And
well, we all have thyroid gland, exactly. Which is an important gland that's sort of in the throat area, and that gland makes thyroid hormone. And that thyroid hormone is important because it helps to regulate what we call the metabolic rate. That means, you know, when you talk about metabolism, you talk about, you know, whether or not anabolism, which helps to produce things, and catabolism, which means to break down things. But very often when you're talking about weight, and a lot of people, we have experts in weight here from Dr. Bay and Dr. Fredericks. A lot of people believe that if they have trouble with their thyroid, which hypothyroid, which means that they have low levels of their thyroid hormone, their metabolic rate is decreased, and for the same amount of caloric intake, they will put on weight. On the other side is if they have an increase in their thyroid hormone levels, their metabolic rates are increased, and for the same amount of calories in, they might lose weight. And so when they say I have thyroid, it's kind of hard to know whether or not they have a hypothyroid condition or a hyperthyroid condition. But if you have a hypothyroid condition, the usual treatment is to take a thyroid hormone supplement. And again, if it's usually something that's permanent, you have to take that supplementation for the rest of your life. If it's hyperthyroidism, they might want to do something to sort of blunt it, or maybe even do surgery to try and deal with hyperthyroidism. So it's difficult from the question to know what they meant by I have thyroid or not, but that's the usual situation.
All righty.
Right.
Well, it's just to add here.
Chime in a little bit, and that's with regards to the question on the glaucoma issue. irrespective of what it is, understand that the eye is a globe, and there are two chambers basically. There's the anterior and the posterior, and there's fluid that's bathing those areas, and there has to be a balance between the flow between the anterior and the posterior. And of course, you have all the huge innervations that come to those nerves, and they go directly to the brain and the different portions of the eye. I think there are about 6 muscles that supply the eye directly with the muscles and everything, and then vision, we talk about. Now, in between those areas, you have the lens, of which, of course, sometimes you have a causation of the nerves that can eventually result in, cataract, depending on the disease, either from old age or from diabetes or from any other chronic medical disease. And now, when you talk about glaucoma, what I essentially do is, you see me for the first time, I tend to send people to go get their eyes checked to ensure that, one, the pressure within the eye is normal, just like we have pressure in our arms, the body, the systemic, pressure that we tend to measure. There's also pressure within the eye, and that's where the tendency comes when you talk about open end glaucoma and closed angle glaucoma. And that's because, not to go into too much exoteric details about that, but one with a closed angle glaucoma, where there's a mesh network that filters the fluid between those chambers, get occluded for one reason or the other, and the pressure builds up really quick. Those are the ones that tend to give you eye pain. Now, the open-ended glaucoma don't tend to give you eye pain. Now, in regards to what his question was, if those in Caribbean are more avert to glaucoma or not, well, what we know that people in around the equator tend to have a little bit more than usual, either because of the direct sunlight of the sun on the equator itself, where most people live around. So in Africa and around the Caribbean area, if you look at those of us who are come from those areas, in the ophthalmology world, they tend to call something called vernal conjunctivitis. Vernal conjunctivitis, either from the UV light, the UVA, UVB, that increase the risk of inflammation and changes within the eye, tend to obstruct the flow. So maybe that's the reason why we tend to have individuals with glaucoma more in those areas.
All right, thank you, Dr. Louis. That was a great explanation of glaucoma. Thank you very much. The next question is, good afternoon. Thank you for all the advice and wisdom. Regarding long-term use of blood thinners, like warfarin, is it safe or healthy to take it for life, take them for life, especially if they are prescribed at a young age? Do they contain harmful ingredients? Are there natural alternatives with fewer side effects that can thin the blood to therapeutic levels? Can someone help us as far as this is concerned?
Well, they're very safe to take long term, and it depends on the reason why you're taking it. I believe that most people do not have to take it long term, but there are some conditions. There are some hypercoagulable conditions like protein C deficiency, protein S deficiency, and others, where you will have to take blood thinners for the rest of your life because your body is made up that way. You don't make enough substances in your liver that cause your blood to get thin. Now, most young females that have to take blood thinners, it's usually caused by a DVT or by a clot, and that usually is in some cases caused by birth control pills and other issues. But there are certain conditions also that young females have, for example, lupus, that predisposes them to clot. So it depends on the reason why you have the clot in the first place. Certain conditions need for you to take it for the rest of your life, and they are safe. I mean, they essentially act by inhibiting certain clotting factors in your blood. So they are safe. They can be taken for the rest of your life. Some of them do have some slight side effects. I think where we're going now, instead of taking Coumadin or warfarin, which is the old standard, where you would have to take your blood work every week, do a PT and your INR every week, we have now, factor 10, the factor 10 inhibitors, the Eliquis and the Xareltos and stuff like that are easier to take because it does not mandate that you take blood work every week for the rest of your life. So the short answer is that yes, they're very safe. And two, you may have to take it for 6 months or a year. It depends on if you had one clot in your leg, if you had a pulmonary embolism, or if you had 2 clots, and if you do have a hypercoagulation. So that depends on what we find when we work you up. Some patients don't have to take it for the rest of their lives. It's only a 3 or 6 month deal. Some patients have to take it for the rest of their lives. And also, as far as it relates to oncology, cancer itself make you hypercoagulable. So a lot of cancer patients have to take blood thinners for the rest of their life. These patients we give Lovenox too, because it has some anti malignancy effect also. But it's not a yes or no answer. It depends on why you're taking it and what condition predisposed you to have to take it in the first place.
Dr. Lane, you said hypercoagulable. What does that mean?
It means that you have a blood, that your blood have a tendency to clot for lots of reasons. There are certain substances that your body produces naturally, protein C and protein S, that are produced in the liver. That that
don't get too technical about these proteins.
Yeah. Not too technical.
Okay. Well, there's certain substances that cause your blood to just thin out. I mean, that's the way you're born. That's the way God made you. And in some patients, they don't have enough of it, so the blood tends to get very thick and they clot very easily. So hypercoagulable means that you have a tendency to clot.
Excellent.
I think just to add one point, though, in terms of the rationale for taking them, I think we always have to weigh the pros and cons and the risk of taking versus the risk of not taking. If you've had certain heart valves replaced, for example, or if you have atrial fibrillation, which is an irregular type heartbeat, which is among the commonest heartbeats that we see, the commonest sustained irregularity we see in the older patients. If it is determined that your risk of forming clots either on the valve or forming clots in the heart, which can shoot off to other parts of the body, especially the brain, and cause strokes. If you are determined to have a significant risk if your blood becomes too thick and you form clots, then it is important, mandatory in fact, that you continue taking blood thinners of whatever kind are prescribed. You take blood thinners for the rest of your life. So it is well known now that many of these blood thinners can be taken over long periods of time quite safely. The concern is bleeding that one may have with trauma, bruising, falling, et cetera, et cetera. But by and large, if it is determined that the risks outweigh the benefit, you don't take them. If it is determined, or your doctor would give you, if it's determined, however, that the benefit outweighs the risk, then by all means, you should take them, and for as long as they are prescribed.
But and also, let me just add that there's some patients that will come and say they went to a naturalist and he gave them something that is a natural blood thinner. And they want to take this instead of taking the medication. I would would advise them strongly not to do that. But you have naturalists out there that are saying these things that they use. The natural stuff is as good as for example, turmeric. I mean, it's some patients just take turmeric 3 times a day because it's supposed to thin your blood out or something like that. It probably does have an anticoagulant effect, but I don't think it should be used to treat DVT.
Right. DVT is
thrombosis. But I think I was going to say that Dr. Garrison has left, but clots tend to form when there's low blood flow, and that's when Dr. Athley talked about atrial fibrillation, where the movement of the blood in the upper chamber sort of might be slow, might predispose to form clots. Or when people have surgery and they're recovering in bed, they want to get them up because they can develop clots in the pelvis or clots in the legs. And if some of the veins that have valves, if they become incompetent, the blood gets slow and they may tend to form clots. So whenever there's a tendency to form clots, there may be a recommendation to look at maybe trying to take a blood thinner.
Okay, all righty. We're going to move on. There was another question that just recently came in. I was in a car accident about 2 years ago, and now my neck hurts all the time. Can you recommend something that will help? Dr. Davis, can you help us out with that one?
Absolutely. So being in a motor vehicle accident is definitely going to have an effect on the 7 vertebrae in the neck. The head rests on top of this. And the fact of the matter is that it's very unstable. So the whiplash type of motion that occurs when a person is hit in a motor vehicle accident obviously causes blood vessels to bleed, muscles to tear, ligaments to tear, et cetera, et cetera. So in terms of getting relief, generally speaking, what side of the neck they're feeling the most amount of pain, we recommend that they apply a moist, hot compress to that area. At the same time, on the opposite side, apply an ice pack. You want to do that for 20 or 30 minutes with a gap of 30 minutes in between. You can do it as often as you can. And what that will do is that will increase the the blood flow to reduce some of the inflammation until we can get them in the office, realign any segments that may have been knocked out of alignment that are pinching these nerves. You've got eight cervical nerves in the neck area. And so any or all of these nerves could be pinched and irritated with that whiplash type of movement. It only happens in a second, but that head can go forward or backward anywhere from 6 to 8 times in that very short period of time, tearing those soft tissues. So that's a treatment that you can do before you receive the appropriate care of being able to reduce the inflammation, take some of the stress off of the muscles, and allow the body to be able to begin to function a little bit better.
All righty, thank you very much. Anybody else want to chime in, or we'll move on? All righty. There was another question that came in. I'm an African-American female that is overweight, and I love my soul food. Since being overweight or obese increases the chance of getting COVID, how can I lose weight in a healthy way? Is Dr. Fredericks around, or is he? All righty. There he is. There he is. Come off mute, Dr. Fredericks.
I was asking a question on the web. Yeah, there's definitely a way of eating healthy, and it's ultimately about eating healthy. Nutrition is what really drives weight management, and so you want to make sure that you're eating whole foods foods. And so soul food can be healthy, and Dr. Bay will tell you it's the portion of how much you're eating. You want to make sure that you're eating a certain portion that's going to allow you to lose that weight.
Mm-hmm. Yeah. And portions are important. I really believe in balanced meals as well. Some of the things that that I preached for many years is that we need to decrease the foods that have increased sugars or increased carbs. If we can decrease that and eat more vegetables, and vegetables have more vitamins, it has more minerals, it has a lot of things that at the cellular level we need to make sure that our cells stay healthy. And if that's the case, if you eat an appropriate amount of protein and decrease your carbs and sugar, increase your vegetables and your salads, I think that's the best way to stay healthy. Dr. Fredericks, do you agree?
Yes, I totally agree. Decreasing that carbs decreases your makes you more insulin. Increasing carbs leads to insulin resistance, and insulin is the major storage hormone. And so when you have a lot of insulin resistance, you tend to become heavier and heavier, and you tend to get that insulin belly fat, that fat that's right around the central portion. That's usually a person who is more insulin resistant. And we alluded to that insulin resistance leads to hemoglobin A1c, getting worse and worse. That's what Dr. Sprout talked about. It's a progression, and it can lead to diabetes. So it's a real close link between obesity and diabetes. And eating refined sugars tends to let your insulin levels spike up and down, and having that insulin level spiking up and down is really not a good thing.
Yeah. The thing of it is that it's interesting because, as our insulin increases, it decreases our sugar. But another thing it does, it drives it fills our fat cells. You know what I mean? It drives those extra calories into the fat cells as well. So we try to keep our blood sugar, in a range as opposed to those increased spikes up and down. Definitely.
Eating more fiber tends to keep that insulin levels more in that range. So that's why plant foods tends to be a better choice than eating those high donuts and things like that really cause your insulin levels to spike.
The things we love, right? We have to, moderation. Moderation is good.
Let me say something. The unfortunate thing with obesity and diabetes is right from way in the 80s, especially here in this country, the picture of diabetes and obesity, if you put the map, was exactly the same.
Yes.
And all that went on till 2013.
Correct.
Where obesity plateaued. And that's because some changes and laws and increased taxation on soda or in beverage drinks that put the drop on obesity. But the unfortunate thing was diabetes did not drop. Diabetes unfortunately kept on going up. So and if you we live in an era where we're talking about COVID-19 now. Studies have shown that if you morbidly obese or obese, you have a 30% risk of severe outcomes with COVID and everybody else. And also we know the correlative association of COVID with diabetes. So if you have a combination of both, that's again a double whammy. And we know how that has done in our community. So it's imperative that we watch out with and control sugar.
Obesity is an inflammatory disease, and that's what causes that. That leads to that with COVID, and COVID cells actually bind to those fat cells and makes it more problematic.
All right, thank you. There's a question that came in, and Dr. Sprock, hopefully you can help us out with this. It's from Tobia. It says, my son has recurring migraines. I'm very concerned. Would any of the doctors suggest a neurological assessment?
Yeah, I think that very often, if a child, how old is the child?
They didn't state. She just said my son, and he is a child. I'm not sure, doctor.
Yeah. So again, migraines are severe headaches, and very often there's a vascular component to them. And there have been various treatments that have been used, and some successful and some not so successful. But I think that very often, if the child has repeated headaches, they should be referred to a neurologist, because one of the aspects is it may be a migraine, but when Dr. Aluya talked about glaucoma, he talked about increased pressure within the eyeball. Well, one of the things that can happen with increased pressure within the cranium, the skull, may lead to pain as well. And so in children, as I'd indicated before, when I spoke a little bit about seizures, one of the things that I don't want to put fear, but is increased pressure in the brain might come from something like a brain tumor. And so I think that it would be important for that child to be evaluated by a neurologist, just to make sure that it's not something that is more sinister, and if it is a migraine, can make some thoughts about what it is. Sometimes there might be a dietary component to what might trigger it, and so it would be important for the mother to start to take a dietary history around the times that this may develop or may not. Now, one of the things that I'm going to say that may be a little bit controversial is the issue of electromagnetism, which is one of the things that has been used for various types of things like depression or something in the treatment of the brain. But as we said, the brain cells are generators of electrical activity. And a lot of the electrical activity that occurs might be responsible for contributing to things that the brain can't fix. And possibly by changing the electromagnetism around the brain, it might alleviate some of these kinds of symptoms. So it's something that is not part of typical Western medicine, but that may be something that might be unusual, that might play a role, because with most things in the body, there's an attempt to fix it. And as we talk about these things, there's a balance that goes on, and this a way that the brain sort of balances everything is something that's important. And sometimes it's not able to do so. But I think it is something that should be seen by a neurologist, and the neurologist can make some suggestions as to possible treatments.
All righty, thank you. All righty. There was another question. It's a little vague, but I want to go with it anyway. Because I think we can tie it into some of the diseases that affect Black and brown people. What's the most persistent disease among the Black community? And what are some of the remedies or medicine people use to get rid of them? So in thinking about this, I'm thinking about hypertension, I'm thinking about diabetes, I'm thinking about heart disease. I mean, can we chime in on some of this?
Obesity.
Oh, yeah, that too. That's probably up here, right? But can we chime in on this? Maybe we can start off with hypertension. We haven't talked about that as of yet, and then get a little bit into some of the other things, maybe even kidney disease a little bit. Some of the things that most of our patients when they come in, I know when I go and make rounds in the ICU, I can start the history off, diabetes, hypertension, heart disease, renal insufficiency. So let's talk about these for a minute. And someone like to start it off.
Well, I'll start out with hypertension and pass it on to Trevor. First of all, when you talk about blood pressure, a normal blood pressure consists really of three things. It consists of the vascular volume, or the volume within the blood vessels, the vascular tone. Remember that the arterial vessels have a muscular layer to them. And so if those muscles are tightened, that will increase the blood pressure. If those muscles are relaxed, the blood pressure will decrease. The same thing, if you have an increase in the blood volume, that will increase your blood pressure. A decrease in the blood volume, that would decrease the blood pressure. And the other thing, and that's an important thing, is how forceful the heart contracts. If the heart contracts forcefully, that will increase the blood pressure. If the heart is blunted in its ability to contract, that will decrease it. So whenever you talk about an increased blood pressure, and there are ranges, especially in children, they have normal ranges of blood pressure that change with age. But we were talking about an increase in the blood pressure. And so if you're talking about an increase in the blood pressure, the medications that are used to treat the blood pressure will either decrease the forceful contraction of the heart, cause the blood vessels to relax, or decrease the vascular volume, which means usually a diuretic or a medicine that's going to cause you to pee out some of the fluid that's within the blood vessels. The same thing would happen if you were to have trouble with your blood pressure was on the low side. You would give volume, an IV of fluids in order to increase the blood volume, give something to decrease to increase the vascular tone, or it gives something that causes the heart to pump more forcefully. So that's sort of the basics of the blood pressure, the high and the low. But Trevor, you can give a more detailed analysis.
Not really. I'd sort of like everyone to chime in from their viewpoint. What I would like to suggest, however, is a concern about the consequences of high blood pressure and the severity of high blood pressure, the frequency and the prevalence in our community. As you know, high blood pressure is found in the highest prevalence in African Americans in the United States. And we're concerned because it can affect many, many organ systems. It's been called a silent killer because many people walk around with significantly elevated blood pressures without any awareness of the pressure being up because you don't feel it. But the consequences are far-reaching. If I focus primarily for a moment on the consequences to the heart, because the heart has to work harder, the heart may undergo certain physiological or functional changes, ultimately occurring to cause the heart both to become thickened and dilated, that is enlarged. So you may get a thickened heart, a stiffened heart as a consequence of the thickness of it, something we call diastolic dysfunction. Dilatation of the heart, that is enlargement, especially of the large pumping chamber, the ventricles, we call them, the left and the right, but more significantly the left. These may all ultimately lead to the heart failing in its function. As you all know, the heart's function is primarily to pump blood around the body. It has to do this as an effective and efficient blood continuously without stopping. So if the heart fails, then one may go into what is called heart failure, just to be repetitive. And this means that the blood not only does not go forward and supply the organs as well as it should, but the pressure and blood back up from the heart towards the lungs and then ultimately towards other extremities. One may see as consequences of heart failure, shortness of breath, lung involvement with fluid on the lungs, peripheral involvement, that is involvement elsewhere in the extremities, fluid on the legs, edema as we call it. So there are multiple presentations, multiple manifestations of heart failure. The failure of forward flow may lead the patients to become fatigued, tired easily, etc. These are some of the consequences that we try to avoid by controlling the blood pressure. This is one of the commoner causes of heart failure. In addition, the high blood pressure also may affect the arteries to the heart muscle. And the heart itself needs blood to flow through these arteries to supply itself with blood. So narrowing of these arteries as a consequence of high blood pressure, one of the factors that may contribute to this. So that narrowing of these arteries can give rise to chest pains and heart attacks. So another one of the consequences we'll see of high blood pressure is heart attacks. We can then talk about some of the other organ systems, but I'll let some of the others take up the other areas perhaps to talk about the kidneys that may be affected, how in the African American population, we have many times, maybe up to 3 to 4 times the incidence of kidney failure when compared to others, etc. Strokes, these are also a consequence. Now, know that Nelson, for example, has had some adequate theories as to why we have more hypertension and relates it to the slave trade and our travel across the Atlantic. You want to take this very quickly, Nelson?
All right.
We've had this discussion.
Thank you, Dr. Trevor. If I may take on from that, no doubt, I often joke. I said, when God created man and created black, well, as you all know, life began in Africa, and all of humanity began in Africa, and every human being on earth have a black DNA. So that's aside. But coming to the disease that affect us, you just talked about hypertension. Another one which is huge is diabetes. And if you all know, today is November 14, 2016. Right. It's actually World Diabetes Day.
Oh,
so diabetes, currently about 440 million people on earth have diabetes. And that number is increasing. By the year 2045, that number will go on to like 770 million. And by the year 2060, it will be 1.2 billion people on earth who live. Now, in this country alone, we have about 32 million people who live with diabetes, and about 89 to 90 million people who are pre-diabetic. So like I said earlier on, we have to pay attention to this because the incidence rate of diabetes in our country, here in the US, is far more in African Americans than any other race except Native Americans, where I think our incidence rate is about 17, they're 17 and ours is about 11%. So it's imperative that we must pay attention to this because diabetes affects every organ in the body, from the head to the foot. Strokes, going blind, heart attacks, the GI tract, where you can't absorb your food anymore. And of course, in men, erectile dysfunctions, and kidney, #1 cause of kidney in the world, amputations and all that. So we must pay attention to this. And if you see your doctor, please always ask him, Doc, what is my A1c? That is the number that's attached to, what your sugar control has been within the last 3 months. So it gives you a fair idea of what it has been. And I always say this now, everybody should know their diabetic status. Are you no diabetic? Are you pre-diabetic, or you're diabetic? And if you are, then you have to begin to take steps into managing it and mitigating the adverse outcomes. Now on the kidney, studies have shown the African American black population in the US is about 14 to 15% of everybody. Right. But guess what? African Americans constitute about 34% of those who are on dialysis. And there's a reason why. So again, if you manage your diabetes, if you manage your blood pressure, keep your weight down, you will go on to manage, protect and prevent, chronic kidney disease. So if you go to see your doctor, just like you ask what your blood pressure is, your A1c status, please ask doc, do I have any protein in my urine? Because if you do, it begins to tell you the kidneys begin to suffer from one or two things. So it's important we check that.
All right, thank you. There was another question that came in. Does having blood in your bowel or in your bowel movements mean that you have cancer?
No, it doesn't.
Okay.
It doesn't necessarily mean that you have cancer. It could be that you could have cancer, but having blood, red blood, could mean that you just have probably, diverticulosis, or you could have hemorrhoids, or you could simply have a polyp that is bleeding. But having blood in your stools needs to be investigated, though. I mean, you just can't have it. Even if you have had it once and it goes away, it needs to be evaluated. I've had patients where they said that, well, it only happened once and it stopped before. That's probably a bad sign. Probably bled and stopped for a reason. So once you have blood in your stool, it needs to be evaluated. You need to have a colonoscopy. But I think most cases, would be benign, but it can be a very serious sign also.
I think the short answer is that the red blood cells, which is blood, is contained in blood vessels, and if you have disruption of the blood vessel, a breakage for whatever reason, then that'll lead to bleeding. So if you're talking about bleeding from the gut, you're talking about some blood vessels that have been damaged for whatever reason, and most commonly it's going to be inflammation. So, you're talking about an itis. So you can have colitis, gastroenteritis, ulcerative colitis. There are lots of itises that you can have all along the way. And so there's certain kind of bacterial kinds of infections that are very commonly associated with bleeding into the gut. Hemorrhoids can be another issue. So there are lots of reasons that you can have blood, and again, I think the most important thing is to determine what is the cause. If it is something like a gastroenteritis that's usually lasts a couple of days and gone, and that's the extent of it, that's great. But you got Salmonella, Shigella, those are bacteria that actually the bacteria invades the gut, damages those blood vessels, and leads it to be bleeding. So a lot depends upon how much blood is there, if it's just a small amount or a large amount. If it's a large amount of blood, depending upon how high it is, the stool won't be red, it'll be tarry and sticky. So I think that it is an indication that there's something wrong, but it could be minor or it could be major.
But I'd like to add that if it is an itis, usually you would have pain. And I think if you have an itis, it's actually not a bad sign.
Dr. Lane, itis, inflammation, let us know what itis means.
It essentially means an inflammation of the tissue. The tissue is inflamed. So essentially, if you have an itis, most times you would have pain because the nerves would be involved. But what is more dangerous is painless blood. When you see blood somewhere and you have no pain, that's a bad sign. If you see blood in your urine and there is no pain, that is a bad sign. If you see blood in your stools and there is no pain, it's probably a bad sign. Now, if you have blood and there is pain, it's probably inflammation and it could be easily be treated. But when you have painless hematuria or painless blood in the stool, that is usually, in my opinion, a more dangerous sign than having an itis.
All righty, thank you. We're going to make this our last question because we're almost out of time. Is there a checklist for men to go off to make sure that we continue good health? It has to be a quick checklist because we only have a few more minutes, all right? Anybody want to chime in for men? Because we've talked a lot about prostate cancer, we've talked a lot about hypertension, diabetes. As far as I'm concerned, and I want to start off with, see your doctor. Number one, I think more men need to go and see their, number one, get a primary physician, and number two, make regular appointments to your primary physician. Talk about that. Can somebody chime in on that for me?
Well, as a primary care physician, I always say this. First and foremost, know your history. Know your family history. Because often enough, diseases are inherited, and even disease patterns are inherited that we just talked about. In common cases are diabetes. If you find out you have diabetes, those in families where people go blind, most everybody will go blind. If it's amputations, it's amputation. If it's kidney failure, it's a kidney failure. So first and foremost, know your history, know what it is, and share your history with family members because you may also be saving lives. That's one. Two, like you said, get a primary doctor, see your doctor as soon as possible, as much as was set up for you, and then know your medications. Know the medications that you're taking, whether it's the ones that are prescribed or whether the ones that you bought from a health food store. Because sometimes these things tend to interact, often badly as well. So before you go to see the doctor, write down all the information you want to get, right? Questions you have, because once you get there, people often forget. So those are some of the things I will add, and I'm sure other people will add some stuff as well.
Okay, Omar. Okay, on your checklist, know the risks that you can control and control them. You're overweight, watch diet, exercise appropriately, know factors that can be changed that contribute to your risk overall, as well as heart, of course. Know what your cholesterol is like, know your blood sugar, and of course, know what your blood pressure is.
And if you're, and if you're a man and you're waking up 3 times at night to go to pee in the bathroom, to pass urine, check your prostate.
Yeah.
Omar,
Yes.
finally,
Yes, the doc.
I would like to impress on both men and women the need to come to the doctor, not only when they're in pain, especially people from our culture, the Caribbean, they're only sick when they're in pain. Please, there are so many things that are going on. By the time you get pain, it's too late. So the final word is check with your doctor as often as you should, and know that pain is not the only manifestation of sickness.
Absolutely.
Yes.
I'd just like to add that, you know, these annual visits that you get, there are certain things that the doctor ought to be asking you, depending upon what your age is. It might be about whether or not you need to take a vaccine or some of the other issues that are related to that. So, and the doctor may not ask those age-related things. So if you have an annual visit, you should try and look up questions that are usually supposed to be asked by the doctor, so that if they don't ask, you can ask them about it. The more informed you are when you go to a visit, then the better the visit will be. The other thing to mention is that in the day of COVID, we had almost an entire COVID talk last time, but there are now a large number of telemedicine visits. Well, there's certain things that can't be done on a telemedicine visit. You can't have your prostate checked. You can't have your breast checked. You can't have your glaucoma checked, the pressure of the eyes. So there's certain things that are important that you need to. I know there's a fear about going to the doctor and what you might catch, but understand that there's certain things that are important to actually be measured and to be examined.
True, true. Anyone else want to make a final summation, please?
Well, we live in the age of COVID, and a study that came out 2 days or 3 days ago, studies were done in Lancaster and Norwich, said those of Black ancestry tend to have 2 times high risk of contracting COVID than any other race. So please, be aware, be informed, wear your mask, get to social distancing, and if you do have signs and symptoms that correlate with COVID, please call your doctor. I got 2 calls yesterday, so that they'll tell you, how best to protect yourself and what to do and protect your family members as well. Now, before I leave, I always tell this: for those of us of African descent, please get your vitamin D. It's been shown to help out a lot. Really
Understand. Yeah, vitamin D, magnesium, zinc, and a multivitamin. That's my recommendation. Listen, everyone, I so appreciate all the physicians that are signed on with us. We will be here the second Saturday of each month at 1 o'clock. All righty. And I'd like to thank OBHealthy, number one, for sponsoring us each month. And sign on and go to your app store and sign on and take a peek at their weight loss app. I think it's something that it's good for Black and brown people to be able to eat what they love and lose weight and be healthy. All righty. Do not change any aspect of your medical care before you consult your physician. That's the most important statement I can make all day. Until next time, I'm just going to say, we loved having you. We love what we do. And we love the fact that you joined us. So until next time, peace to everyone. All right.
All right.
Bye-bye.
Goodbye, everyone.
All right. Take care, guys.